Good afternoon, everyone. Welcome to our afternoon session. I'm Angie Frank. I'm a pulmonologist at MGH, and I'm one of the directors of this course, and I'm going to moderate our afternoon session. We have a lot of interesting topics coming up for interstitial lung disease. So without further ado, let me introduce our first speaker, Dr. Lita Hariri, who is a pathologist here at MGH and is going to give us a talk on the pulmonary pathology in ILD. Lita?
Great. Angie, thank you so much for having me, and to all the course directors. I'm really excited to get to talk about pulmonary pathology always, but especially in this group. I do have to give a full disclosure because I feel like it's just better to be transparent and honest. Took a flight last night that was quite delayed and came in much, much, much later than expected. So I'm running on very little sleep. Hopefully it will not affect anything today, but if there's some extra stumbles, I ask for your forgiveness. So with that, let's dive right in. Okay, so what we're going to talk about in the next 40 minutes or so is focusing on interstitial lung diseases. And given that this is the first talk in the series of interstitial lung diseases in the course this time, we'll talk about it with respect to the guidelines originally as they've evolved over the years, related to the radiologic features that may or may not designate the higher likelihood of wanting a biopsy, why that might be. We'll talk about the non-IPF ILDs, what the differentials are, what the features look like, how we distinguish them pathologically. We'll talk about multidisciplinary discussion and how the role of a pathologist in particular has really evolved over time, and how you may engage your pathologists at your own institutions or at other MDDs in ways that may be helpful to taking care of your patients outside of just when a biopsy is performed. And then we'll conclude with what I like to call, what type of biopsy should I do? Because that's a very common question that I get, and I thought it would be worthwhile to discuss a little bit today. Okay, so we'll start with focusing on IPF, because I find that to be, not that it's a simple disease, but maybe a simpler place to get started, because the diagnostic workflow there, I think, has been well vetted, even if it's not always the easiest to actually execute. As beautiful as the flow diagrams are, sometimes they're more challenging in real life, if not almost all the time, if not just sometimes. Okay, so when you have a patient who comes in with interstitial lung disease, you may suspect that they have IPF. As clinicians, of course, you already know, one of the main first steps is to see the patient and look for identifiable causes of the disease. Then you'll look at the HRCT and look to see what the pattern is there. And depending on those pieces of information, you actually may be able to come to the diagnosis of IPF in at least 50%, now probably even more percentage of cases, based on certain clinical and radiologic features. And what those radiologic features were for really a definitive UIP pattern has not changed really drastically over the course of the last decade and a half now, if not even longer than that. And what we're really looking for here is a specific pattern of a subpleural basal or predominant fibrotic disease, which is evidenced by reticular abnormality. We're looking for the presence for definitive UIP of honeycombing, which may or may not have traction bronchiectasis associated with it. And then, of course, you're also looking for an absence of any features that may be inconsistent with IPF. Really, that might indicate that this may be another entity, either something that's non-UIP, which is the pattern associated with IPF, or something that may be a UIP pattern that may be secondary to another systemic cause like connective tissue disease, hypersensitivity pneumonitis, et cetera. And so back in 2011, really the big crux that was required for making a definitive diagnosis was whether honeycombing was present or absent. And without that feature being present, it made it more difficult to nail down that diagnosis. Now, these criteria have really evolved over the last decade or so in order to refine criteria to still provide a high level of confidence or positive predictive value, but specifically within the context of a specific clinical context that needs to be met in order to increase your likelihood and really your positive predictive value of a patient having IPF really being idiopathic of unknown cause. Okay, so in the instance where an HRCT is not definitive, whether by the prior criteria or the criteria we will meet, the next step is to consider potentially getting a surgical lung biopsy. Now, we may have other alternative types of biopsies that we'll talk about a little bit later, but for now, we'll focus on surgical lung biopsy, given that that's the place where pathologic features have been the best developed, and some of the newer techniques we are still trying to identify their best role in patient care. So With a surgical lung biopsy, I think a lot are very aware of the benefits as well as the risks of getting this type of biopsy. Unfortunately, this isn't the type of procedure where you're able to go in minimally invasively with just a bronchoscopic approach to do a transbronchial sampling, the way that you can with many lung cancers, or a transthoracic sampling with many lung cancers. Interstitial lung diseases really require a much larger swath of tissue to be able to understand and interpret appropriately what the pathologic features look like across that piece of tissue, importantly from the subpleural region moving more proximally, as well as we need to gain an understanding of craniocaudal distribution of disease. So what this ends up meaning is we need a much larger piece of tissue in order to come to that accurate diagnosis that surgical lung biopsies are quite well known for. And so typically what we recommend is two, if not possibly three biopsies from multiple lobes on one side of the lung, ideally an upper and a lower lobe. If a middle or a lingula can also be biopsied, that's often very helpful. But those decisions of where to biopsy is also very dependent on the distribution of the disease, the prominent area as well as the less prominent area as well. We typically are looking for pieces, I'd say, that are maybe a little bit shy of golf ball size, but that's about the size of a procedure, of a tissue that we're looking for. Now, with an invasive surgical procedure like this, there are risks of mortality that have been reported with elective procedures being, I'd say now in the literature, somewhere around 1%, with some studies actually indicating even lower. Newer studies have come out, one in fact this past year, that has shown that there may not even be an elevated risk of mortality or a significantly increased risk of morbidity when patients are really carefully selected to minimize any patients who might have a pre-existing high perioperative risk. However, there is a risk. This is an invasive procedure, and so it needs to be considered with caution whether it's really worthwhile to get this tissue, and how is that going to guide your management. Okay, so now when we look at the newer guidelines that came out in 2018, both from the American Thoracic Society as well as the Fleischer Society, very, very thankfully to both groups, there was a lot of homology within the recommendations from both of these, really fabulous groups. But I think one of the big changes that occurred was to start to push the needle a little bit more towards not needing just a definitive diagnosis of UIP by radiologic interpretation, but now also being able to accept a probable UIP pattern in an appropriate clinical context of a male who's over 60 and a former smoker with no other suspected or known risks for a secondary cause of disease like connective tissue disease, hypersensitivity, et cetera. In those patients, when we look at the data, we actually find that the predictive value for likelihood of IPF is quite high. And so these criteria have now moved in this way to reduce the number of patients who will require surgical biopsy for a definitive diagnosis. Now, really, when you start to think about this, what it's coming down to is almost, for lack of better terminology, hedging your bets of how likely is this context or this scenario of this individual patient to be a high confidence of an IPF in that specific individual by balancing the HRCT and clinical findings you have. And then if you find that you don't reach quite high enough confidence just at that level alone, then bringing in the histopathologic pattern so that when you put all of the pieces you have available together, you're able to come to the highest likelihood diagnosis possible. Now, with the high-res CT features we were talking about, of course, we've known for a long time that a definitive UIP pattern has a very high positive predictive value when you compare it against a concurrent surgical lung biopsy that's done for predicting UIP on a surgical lung biopsy. When you look at probable UIP, the positive predictive values there are reported to be around 80%, but I will note that there's quite a range, and with positive predictive values, it really depends on the prevalence of your disease, and specifically within the studies, the prevalence of IPF within those diseases. So for example, studies that used cohorts that were patients referred for IPF studies but didn't qualify are obviously going to have a higher prevalence of UIP pattern because there was already a very high suspicion that they may have IPF. They've been referred to a clinical trial, versus those that are just all comers and instances where places you may have only a 30% IPF prevalence across your patient cohort. Those positive predictive values tend to be more in the 60% range, even some as low as 50. Now, when we look at the other categories radiologically of indeterminate versus alternative diagnosis, my wonderful colleague Amita Sharma will be speaking after me to talk about what all of those features are. So I won't get into that. but I will speak to how we use this from a pathologic perspective, whereas an indeterminate essentially means that it could still be IPF, and about 50% of these cases will still be IPF. Some of them may be secondary UIPs of another etiology like connective tissue or hypersensitivity pneumonitis. And some of these cases may be a non-UIP IPF diagnosis entirely, so not even a UIP pattern, but an NSIP pattern, an airway-centered pattern. Then finally, alternative diagnosis essentially indicates radiologically that the radiologist interpreting the read really favors that this is a disease that is not IPF specifically. So I'm not certain it could be, it couldn't be, but really there are features here that indicate a likelihood that this is something else. But I will say there's still a 20% positive predictive value within that category. So about 20% of those patients, when you biopsy them and you look at their clinical course over time, will actually turn out to be IPF patients. And so specific diseases each have their own criteria that have their own positive and negative predictive values that need to be taken into account when utilizing HRCTs and the decision to make surgical lung biopsies across all of ILD, not just in the likelihood of IPF, which again is sort of the complexity and the beauty of practicing in this particular arena of pulmonary medicine. Okay, so now why is it that we even need a surgical lung biopsy? Like, why can't HRCT just solve all of my problems as a pulmonologist? So I just never have to get a surgical lung biopsy. And believe me, I in some ways, I wish it could. But unfortunately, really where the limitation is the resolution that even high resolution CT is capable of. And so when you think about this, not from a theoretical resolution, but from what structures are readily resolvable on an HRCT scan, we know that that limit is around 2 millimeters. And really the way that we know that is in normal patients, we know that we're not able to see the small airways that are 2 millimeters and smaller. And so typically then structures that are under that 2 millimeter threshold become difficult to distinguish between other features. They may still be visible as something like ground glass or reticulation, but those individual features may not be as evident as if they're on a larger scale. So when you have honeycombing that's under that 2 millimeter diameter size range, that's why sometimes you'll see that type of microscopic honeycombing, as we call it on pathology, but it won't be reflected on the concurrent radiologic image that's been taken. Now, again, I think another place where, although I think this was evident in our practice, regardless of what the guideline says, the newer guidelines have really put a very heavy emphasis on having MDDs as frequently as necessary, and really at any important clinical juncture of I need assistance, or I need some additional information or input related to this particular patient in order to determine how confident is my diagnosis with the information I have? Is it enough for me to go ahead and make decisions about not only diagnosis, but treatment, as well as prognosis for the patient, if that becomes an important factor? Or do I really need to consider some alternative testing in order to increase my confidence, really mostly to drive treatment decisions? I think it's also important to recognize at this stage in our field that right now our treatment options are not vast. There's immunosuppressive therapy, there's antifibrotic therapy, and then there's the possibility of combining the two, which somehow in some ways simplifies that specific question of, do I need more information in order to make a decision about how to treat this individual patient? However, as new therapies roll out, I think that this particular question is going to become more challenging and more complex in terms of, when do you make a decision to choose a specific therapy if there's more than one fibrosis targeting therapy available? When do you make a decision to switch? How are you going to measure those factors? And I think, I don't know that necessarily pathology is the way to do that, but it may end up being a more important factor moving forward. So still lots of interesting growth happening in our field for all wonderful things. Now, one thing I really like to specifically point out when giving these lectures is that although MDDs are traditionally described as formal conferences where, maybe previously we used to sit down in a room, maybe some groups are still sitting down. A lot of us are doing this now virtually by Zoom or Teams, where we all get together and discuss individual patients. However, I don't think that that's necessary in every single case. And sometimes there can be what I call almost a pre-MDD, where there can be an informal conversation between colleagues, either within an institution in order to help put information together rather than each discipline working in isolation. So an example of that here is a conversation that I actually had with Amita Sharma, who'll be giving your next lecture on CT, where I had a pathology read that I was pretty confident about what I wanted to call it, but I was curious about her CT interpretation in order to understand where there might be misalignment. I wanted to evaluate if there was a potential for sampling error. And so we just had a quick conversation and were able to answer that question quite quickly. Then we're able to provide that information to the pulmonologist taking care of the patient so that that didn't have to happen at the formal MDD. It happened ahead of the MDD. So we already had some of those particular questions answered. But I think it's also important that if you don't have access to to specific colleagues that you would like information from, it's important to have colleagues at other institutions that you can reach out to, whether across disciplines or within disciplines. There's now lots of programs also available, such as ECHO ILD, which we have a center here that Rob Hollowell and Alia Barkarat run, where people all over the nation and actually globally are able to submit cases to get input from lots of different individuals in the ILD field. And so that can also be an option if helpful. Okay, so now the role of the pathologist in MDD, I think there's the classical things that we've always thought about, that if a biopsy's been done, yes, we really need a pathologist there to be able to assess what the pattern is, what's the etiologic differential that's associated with that pattern. Is there a presence or absence of specific features that might indicate an etiology very specifically, such as peribronchial or granulomas, which we'll talk about, versus lymphoid aggregates in CTD. We then take the context of those findings and discuss them in the clinical and radiologic context. However, I think now as we're moving towards more precision-based medicine for your individual patients, where we're taking the biopsy decision much more thoughtfully and carefully to really answer that question of, is it going to really change what I do? It may be helpful to have the pathologist involved in that discussion to ask that this is my specific question. And based on if we were to get a biopsy in this individual patient, how likely do you think it is that you'd be able to make the distinction between X, Y, and Z differential diagnosis? And in some instances, the answer may be, oh, absolutely, there's no question. In other instances, we may say, that might be a difficult distinction to make with this specific type of biopsy. But if you get that type of biopsy, we may be able to be better. And that way we can, really have an open conversation before a biopsy is even undertaken. Also, I think very importantly is involving the pathologist and your surgeon as well in conversations related to adequacy and making sure that your individual center understands what adequacy means and how to select tissue sites for biopsy, specifically with the surgeon correlating together with the pathologist, as well as to make sure that there hasn't been any sampling error. And I think in some instances there, in cases that we get from the outside, we occasionally see instances of sampling error where you can tell that the area of abnormality was not biopsied or sampled appropriately to get to the diagnosis we need. But in most centers that practice ILD quite regularly and do biopsies regularly, this really becomes quite infrequent, where we're not able to make sure that the sampling we get pathologically is reflective of the underlying disease. Okay, so now let's talk about what the pathologic criteria of UIP and the things that are in the differential of UIP are. Here is an example of a classical UIP, which I'll be honest with you, would never get biopsied anymore, because I can tell you right now, these honeycomb cysts are well over 2 millimeters in diameter and would clearly be visible on CT. But it's a nice case to be able to illustrate really clearly what the pathologic features look like. And so what we're looking for is areas of honeycomb change that are embedded within fibrosis that has distorted the underlying architecture. And what that means is that this fibrosis that starts in a subpleural distribution and extends down the pleural reflections of the septa, then isolate off lobules of the lung, essentially replacing the normal lung parenchyma or alveolar spaces that are present in that arena, and collapsing it down with fibrosis, leaving behind what we call honeycomb cysts, which are basically remnants of this localized end-stage process that's occurring at each lobule. So what's fascinating about this, when you think about this from a pathologic perspective, is that in UIP of IPF, you're basically having micro end stage disease happening lobule by lobule by lobule. And as you progress the disease, basically those lobules continue to get essentially obliterated. So you're not able to have obviously efficient or really any gas exchange by the time you get to the level of honeycomb remodeling. But this is, happening on a very microscopic scale when you really break it down at the earlier stages of the disease, where lobules are individually being picked off, in essence, by the fibrosis. Now, of course, with UIP of IPF, we're expecting there to be what we call spatial heterogeneity. So there should be alternating areas of normal lung with areas of fibrosis with honeycomb lung. We're also looking for a subpleural disease predominance, lower lobe predominance, just as we see radiologically. And then finally, really the hallmark of the pathogenesis of the disease is to look for temporal heterogeneity, which, to be honest, from a diagnostic pathology perspective, is not a crux of how we make the diagnosis, but it really is the heart of what this disease is that we have these areas of young collagen that we call fibroblastic foci, which are the individual foci or nidus, nida. I don't know what the plural of nidus is. Forgive me for my jet lag this moment. Essentially, these are areas where you have active injury that instigates young collagen to come in, heal the localized wound, and then unfortunately that wound does not remodel back to normal lung. It remodels to established fibrosis. This is really what continues this progressive disease on and on and on throughout the course of the disease within a patient. Now, importantly, pathologically, I think from a pathology perspective, it's really important for us to indicate when we see a high number of fibroblastic foci, because we know that there's been multiple studies that indicate that inversely correlates with survival and often can be an indicator of a patient who may be undergoing an accelerated phase of a disease when they're specifically high, or even who's having an acute exacerbation or just on the cusp of acute exacerbation. And so we often will report that and make sure the pulmonologist is aware that that's present. Okay, so now what is honeycombing? And so I like to think about this as honeycombing is specifically the remodeling of the lung and the simplification or the remnants that are left behind, which are cystic spaces in essentially what appears to be honeycomb, and the way that the cysts are arranged with one another and the rigidity of their walls. But importantly, these honeycomb cysts are isolated from the pre-existing tracheobronchiolar tree. So they're isolated cysts, often mucin-filled, often respiratory epithelial or squamous epithelial line, depending on the level of injury that's happened in that space. But they're isolated, which again is why they really impede with the fibrosis destruction and the honeycombing there, the gas exchange propensity within that specific lobule of lung. Now, in contrast to that, traction bronchiectasis, or really more importantly, pathologically bronchiolectasis, is the traction bronchiolectasis is where you take that pre-existing tracheobronchiolar tree and you dilate it to create cystic change, but it's cystic change of the pre-existing tree. Now, this may feel like semantics, that what does it matter whether it's traction bronchiolectasis or honeycombing? And from a radiologic perspective, in some instances, that distinction may not be important when distinguishing, for example, probable UIP versus definite UIP. But from a pathologic perspective, it's actually quite important because it helps for us to isolate out whether there's an airway centricity to the disease or this is really truly subpleural disease, which then helps us to inform what the likely etiology might be of that disease. And we'll see examples of that airway centricity in just a few slides. Okay, now probable UIP pathologically is not probably UIP. I think that's an important distinction to make. What this is it's UIP that's missing a histologic feature that doesn't either, it's not present or it's not present to the extent that's necessary to have a definitive diagnosis of UIP. Now, I would say the number of cases of probable UIP that I diagnose is incredibly small pathologically. An example here is a biopsy that was done where we had quite a bit of subpleural fibrosis. There was numerous fibroblastic foci. There's spatial heterogeneity with preserved lung next to fibrotic lung. The only problem with this biopsy is that we didn't really have sufficient honeycombing present. There was only a couple of isolated cysts. And so this was a case in which we called it probable UIP, and in the appropriate clinical context, it ended up being called IPF. But in general, pathologically, it's rare that we run into cases like this because the features usually are present enough that we're able to decide that this really does look like UIP, or alternatively, there are features present that are indicative that this might be another non-idiopathic etiology, in which instance we wouldn't call it probable UIP. We'd actually move this to an indeterminate for UIP or an alternative diagnosis. Now, I just briefly flipped over this slide. I'll mention it because it's part of the guidelines, but it's really a non sequitur anymore because it's not a problem we run into very frequently at all anymore. But biopsies that contain only end-stage lung with no preserved alveoli, because you don't have that spatial heterogeneity, that would be an instance where we would have called it probable UIP. However, again, the extent or sort of stage of disease a patient has to be in order to get a biopsy that looks like this is really at this point too advanced that a biopsy would even be considered. So this isn't a situation we run into very often anymore. Okay, now when we go to indeterminate versus alternative, really the distinction here for us is either if it's alternative, we're really confident that this is something other than a UIP pattern related to IPF. So either it's got a histologic features that are classic for another pattern of disease that's non-UIP, or it has very clear secondary features that tell us that this is not UIP of IPF. So for example, again, peribronchiolar granulomatous inflammation in the presence of a UIP pattern would tell us that this is not likely to be IPF. It's more likely to be fibrotic HP with a UIP pattern. Now, indeterminate for UIP is, again, where it's really a pattern that's either favoring something other than UIP altogether because the distribution doesn't match for UIP, or it's a UIP, but the UIP has some features that make us suspicious that it might not be due to IPF. It may be due to a secondary etiology, but our confidence level is not high enough to move it to a full-fledged alternative diagnosis. And we'll see some examples of that in the coming slides. Okay, now from a pattern perspective, the differential that we have for UIP is nonspecific interstitial pneumonia, or NSIP, which differs from UIP in that we have a more homogeneous thickening of specifically the alveolar walls without destruction of the alveolar spaces themselves. So what you can see if we look here from this subpleural space and we move proximally, there's plenty of white alveolar spaces present all the way through. What's abnormal about this case is that the alveolar walls are rigid and thick with fibrosis. Now, NSIP can be either idiopathic or more frequently it's secondary to another etiology, typically an autoimmune-related disease. Things like scleroderma tend to present with NSIP. Some myositis does as well, or also with fibrotic HP in some instances. Although typically with a fibrotic HP, you will see an airway centricity if you look carefully because that disease tends to more heavily affect the airways. Here's just a higher power picture. Now, with airway-centered fibrosis, when you look at the disease pattern, what you actually see is that the fibrosis, although here touching the subpleural region, it's not interested almost exclusively in the subpleural region moving in towards the lung. Here, when you look, the bulk of disease is actually centered around these small bronchovascular bundles or airways, really defining this as an airway-centered disease. Now, when we see an airway-centered pattern like this, typically what that indicates for us is that something is injuring the airway, which is not something we typically see as a pure pattern in a patient with IPF. There should be a subpleural component that's the dominant pattern. And in some instances, you may have a small component of airway-centered disease, but when it's this much, from a pathology perspective, we're like, there's no way this could ever be a UIP of IPF. This is much more likely to be a hypersensitivity pneumonitis, so we would look for peribronchial granulomatous inflammation to see if that's present to nail that diagnosis down further, or a connective tissue disease, and we look for specific features related to lymphocytic inflammation, its presence, extent, location, as well as evidence of pulmonary hypertension that's out of proportion to the disease that would indicate connective tissue disease as well. Okay, now we're going to switch gears from talking about patterns and now talk about etiologies and what are the features that we as pathologists look for to help guide the likelihood of that etiology. So in a diagnosis of fibrotic or previously chronic hypersensitivity pneumonitis, what we are looking for is the specific presence of peribronchiolar granulomatous inflammation. And the reason we call it granulomatous and not granuloma is these are loose aggregates of histiocytes. Sometimes they're just aggregates of a couple of giant cells that are present together. They are not the tight, compact granulomas that you would see in a mycobacterial infection or a case of sarcoid. They're looser than that, subtler than that. Now, with a fibrotic hypersensitivity, you can have any type of pattern on pathology. It can be a UIP pattern, although you should find these granulomatous areas as well to be able to nail the diagnosis. You can have an NSIP pattern, an airway-centered fibrotic pattern. Most frequently, we see a mixed pattern with different ratios of each component present. Now, with connective tissue disease-related ILDs, again, this particular etiology can have any of the fibrotic patterns present, but what we as pathologists are specifically looking for is specific features of inflammation, either that its extent is too high. So for example, in this case, this is a lot of lymphocytic inflammation that's present. We can see that not only are there lymphoid aggregates, but there's germinal centers in these lymphoid aggregates. That is incredibly unusual to have in a case that's idiopathic. Germinal centers for me are almost pathognomonic for the person having an immunologic abnormality present, and that needs to be investigated further. But in the absence of the germinal centers, when you have an increase in number of aggregates, or if you have lymphocytes through the alveolar wall, or within the pleura explicitly outside of areas of fibrosis, those are also things that we look for pathologically to indicate CTD, especially in a case where it hasn't already been diagnosed systemically, which happens in a small proportion, but not a rare proportion of cases. Okay, now one of the things as pathologists we do struggle with is how much is too much. So for example, we have a case here of a UIP pattern. There is a significant amount of lymphocytic inflammation. So all of this blue here is a bit abnormal, is forming aggregates. Some pathologists, this may be too much, and they'd say, oh, this can't be IPF, it's too much inflammation. For others, they'd say, you know, it's a little on the fence. It could be, it couldn't be. For me as a pathologist, this is suspicious, and I would really encourage the pulmonologist for the patient who has this biopsy to have a very low threshold for repeating serologies, to be very, very careful about looking for systemic symptoms, because as we know, the lung can be the first manifesting organ, and in 6 months, a year, even 2 years, the patient may develop systemic symptoms and then seroconvert at a later date. And so sometimes we can have a little bit of advance warning that may be coming. Okay, we're gonna I have a couple of clinical cases here that we'll go through. Here's an example of a 56-year-old man with a fairly short history of shortness of breath. When we look at his CT, you know, Amita Sharma helped me to interpret this. There's subpleural basilar predominant reticulation. There's a little bit of traction. This patient meets criteria for probable UIP. When we look at the question of, okay, yes, we're at probable UIP. This patient is male. He's a former smoker. He's not quite 60 years old. So the patient ended up having a biopsy. And in this particular case, this was a patient who had UIP, no aberrant features. And so at MDD, this was a pretty slam dunk, easy case for us of, yes, this is UIP IPF, and we were confident in the diagnosis. Now we have a similarly aged woman who had dyspnea and ILD. Pattern has some similarities to our prior patient of a subpleural basilar predominant reticular opacities. There's some traction changes. And then in some areas, our outside radiologist who had seen the patient first with an outside pulmonologist had questioned whether there might be honeycombing there. When we took a look, we weren't sure if it was or wasn't. Let me see if I have that honeycombing. Yeah, I don't know if I have the best picture of the honeycombing, but the bottom line is the diagnosis was in question. And so we patient had a biopsy. And so what we ended up finding is that this patient actually had an airway-centered fibrotic process. So here we can see is the subpleural lung. There's actually subpleural sparing. It's just on a microscopic level, which is why it may not have been visible radiologically. all of this disease, both fibrotic and a little inflammatory, is centered on the airways here. And so this is not a UIP pattern. When we looked carefully in other areas, there was peribronchiolar giant cells and granulomatous inflammation. And so we actually favored that this was likely to be a fibrotic HP individual. So this was a case in which the biopsy was incredibly helpful to help narrow down what the differential diagnosis was from, could this be UIP IPF? Could it be something else? And then in the end to say, no, this is definitively not UIP IPF. We favor that this is a fibrotic HP. Okay. Couple of other things I'll mention here is we've talked a little bit about the pathologist working together with the surgeon and pulmonologist about where to biopsy. It's important to address things like laterality, surgical accessibility. Also importantly, if there's a nodule that you want sampled at the same time, to really clearly communicate that. Unfortunately, I've seen cases from the outside where some of that didn't get communicated quite right. And they were like, well, where's the biopsy of the lung nodule, Lita? And I'm like, there is no biopsy of the lung nodule. And, I think just person who ended up doing the procedure thought it was an ILD biopsy, just did their regular 3 biopsy wedges. And so all of that communication obviously is just helpful whenever dealing with these complex diseases, especially. The issue of avoiding end-stage lung used to be a big bugaboo for a lot of us because there was a lot of biopsy of just entirely end-stage lung. I will say that's, again, not very applicable, and in some instances may be the wrong advice to give to the surgeon, because if they avoid the area of the worst disease in a patient who has early ILD, they may accidentally be introducing sampling error by not getting the area that shows the most abnormality. So again, it's important to have that conversation together with the surgeon and the pathologist in order to determine when there's questions about that. And then I have a couple of other example cases, but for time's purposes, I'm just going to go ahead and pass them. They're there for you in the slides for you to review. And if there's any questions, I'm always happy to answer later. Now, I'd like to spend the last few minutes just talking about biopsy options, the first of which being transbronchial biopsy, which I cannot tell you how often I get asked, not necessarily at MGH but other colleagues, is it possible we might be able to get away with just doing a transbronchial biopsy in order to make a diagnosis in this patient? And the vast majority of cases, unfortunately, transbronchial biopsies are insufficient to make a definitive diagnosis in ILD. And I'll explain what those caveats are in just a moment. But the reason for that is if you take a look at these little tiny blue, terribly drawn things that I've created here, this is sort of a representative sampling of how much tissue we might be getting from a wedge biopsy. I'm sure it's not exactly to scale, but you can get my meaning, I hope. Now, when you take a look both not only at the size of the tissue, but the location of the tissue that you're getting samples from with a transbronchial biopsy, it becomes obvious why it's difficult to use these to make a diagnosis of ILD, because you're not sampling the peripheral lung deep enough in order to evaluate the pattern of the fibrosis, nor are you getting a sufficiently sized sample in order to be able to interpret what that pattern is and make sure you don't suffer from sampling error that may have missed important diagnostic information. Now, bronchoscopic cryobiopsy has really become the newer kid on the block, being used more and more frequently, I'd say, where here you use a freezing probe from a bronchoscopic approach to adhere and then remove lung tissue. And so you get much larger tissue pieces than a transbronchial biopsy. So you can see here, this is a cryobiopsy on the top right. This is a transbronchial biopsy on the top left. However, cryobiopsies typically are not as large as we get with a surgical lung biopsy. Fortunately, I didn't have a fresh, gross picture of a surgical lung biopsy, so I took a picture of a couple of slides. So you can see here, just from this two-dimensional cut, what a larger piece of tissue we're getting. However, there's been some really nice data out there, some of it conflicting, but overall, I think the data has been mostly positive to indicate that there is histopathologic agreement between transbronchial cryobiopsy and surgical lung biopsy. It's not perfect, but it's still pretty good, I'll be honest with you. And in a lot of cases, the use of the transbronchial cryobiopsy was able to provide enough information to achieve a high confidence diagnosis in patients who required the biopsy. Now, the type of biopsy you use and when. So surgical lung biopsy, I would say here, these are with patients who have a low or maybe even a medium confidence ILD diagnosis, where the surgical lung biopsy is likely to alter your treatment decision of, are you going to use immunosuppression? Are you going to use antifibrotics? And are you going to use dual therapy? And importantly, in patients who are not at excessively increased risk for postoperative complication. Now, I will say that we've been having a lot of conversations within the field about empiric treatment of, oh, I'm just going to give a little bit of immunosuppression to see how the patient responds, which is an option and obviously is a possibility of how to approach the patient. However, there are still things to be considered in that scenario of, if you have a patient who doesn't have a diagnosed ILD, we know immunosuppressive therapy in patients who have IPF have actually been shown from the Panther trial to be harmful. So if you don't know for certain they don't have UIP of IPF, but you're giving them empiric immunosuppression, there's always that chance that you may actually be potentially putting the patient at harm by giving that empiric therapy versus finding out what their definitive diagnosis is. Also, it's important to consider that with immunosuppression, you really need to be targeting inflammation, and it's important to know if that inflammation is present. There's been a number of studies that have indicated that ground glass opacities, in fact, one that just came out, I forget what journal it was in, but it was just this week, that basically indicated that the use of GGOs to guide the decision of immunosuppressive therapy doesn't result in positive outcomes for the patients. And so it's important to consider that. Now, transbronchial cryobiopsy, I'd say, is still under debate due to some of the conflicting literature, also variable experience levels across centers and individuals. And there are complications. Although this procedure is less risky than surgical lung biopsy, it's still not without risk, and there is risk of bleeding, pneumothorax. There have been some cases of death, although much less frequently than we see with surgical lung biopsy, clearly. I think really what we're suffering from here is there's a lack of standardization in how to perform the procedure. How many biopsies do you need? Where should they be sampled from? And so here, at least at MGH, we really take this from a case-by-case basis, where if there's a patient who has a bronchiolocentric abnormality on their CT that we want to sample and we think will be sufficient to give us an answer, and we think the cryobiopsy will be a likely way to get that. That usually involves a conversation across the pulmonologists that are present at MDD, our interventional pulmonologists who do the cryobiopsy, and also the pathologists as well. Finally, transbronchial biopsy, I just want to remind you that for the majority of ILDs, this is not a sufficient way to get a diagnosis, unfortunately. I really wish it could be, but it's not. And you will be disappointed time and time again if you try to use this to get a diagnosis. With the exception of sarcoid and some rare cases of HP or organizing pneumonia, in those instances, I would highly recommend that you have a convo with your MDD to really make sure that this is worth pursuing so that you don't undergo a procedure unnecessarily for the patient. And with that, thank you guys so much for your time and attention.